This morning. Again, my name is Matthew Menendez with White Plume. This webinar is designed for physician practices. We're going to be talking about ICD-10 and how to protect your doctor's time, your doctor's productivity, and your cash flow during the transition. So let's go ahead and jump right in and talk about what we hope to accomplish in the next 45, 50 minutes. We're going to start with some background information on ICD-10. Right? I know everybody is probably aware of what ICD-10 is, so we're going to take a bit of a different approach. What we're going to do is we're going to look at some of the things that make ICD-10 uniquely difficult here in the United States. What makes ICD-10 hard? Because there are some challenges that are different than what we've seen in some of the other countries who've already moved forward with ICD-10. And then I'm going to share some mistakes that I see other practices make. There's not a lot of time left before the ICD-10 conversion date. For those of you who are trying to catch up, for those of you who are behind, if I can share some mistakes that other practices have made, maybe you won't make that same mistake. Maybe you can learn from that. And then there's also a lot of bad information, a lot of misinformation out there in the marketplace about ICD-10. A lot of people use scare tactics to make ICD-10 seem worse than it actually is. We're going to try to dispel some of those myths so we can take a good, clean look at what ICD-10 is and what it is not, where the risks are so that you can be prepared to protect against those risks. And then we're going to jump in and get more detailed so that you can understand what the impact is to your practice, what the impact is to your staff, what the impact is to your providers. Which areas are going to be easy, which areas are going to be difficult, so that you can make sure that you have a good plan in place to be successful. And a couple of themes that you'll hear throughout our time today. The first is we're going to focus on physician productivity. That's the first thing that you have to do. In any physician practice, if your doctors aren't seeing and taking care of patients, nobody else is. If your doctors aren't generating revenue for the practice, nobody else is. And at the end of the day, if your doctors aren't happy, nobody else in the practice is either. We've got to keep them focused on what they're best at, why they got into medicine, taking care of patients. But we have to balance that against the real revenue cycle need that says, yep, after we see those patients, you have to make sure that you get paid. And you've got to have the right codes in order to do that. So we're going to talk about how do you protect the doctor's time, how do you protect your revenue cycle, and do that without adding staff. So you'll hear that theme throughout our time today. The other theme that you'll hear is the difference between ICD-10 compliance and ICD-10 productivity. A lot of people mistakenly view ICD-10 as a compliance-only event. They look at it like a pass-fail test in college, or pass-fail course in college. You wanted to do just enough to be compliant, just enough to pass. That's not how it will work with ICD-10. There will be some practices who are very well prepared, who do very well during that transition. There will be others who are not as well prepared. They haven't thought through their workflow. They haven't thought through how it's going to impact their staffing, how it's going to impact their doctor's time, and they will struggle. I want to make sure that's a conscious decision that practices are making, that you're not doing that by default. Some of you may elect to say the strategy that we're going after is really just a strategy of ICD-10 compliance, but that needs to be an active decision. Again, I'll leave time for questions and answers at the end. So again, if you've not already, go ahead and locate the questions panel in the GoToWebinar control section, where you can ask those questions. You can ask for any follow-up information that might be helpful for you. All right, so let's jump in. What makes ICD-10 difficult? What has our government done that makes it uniquely difficult here in the United States? And the first thing is it's a one-day conversion, right? I'm sure everybody is aware of this. The date for the ICD-10 conversion is October 1st, 2015. It's a Thursday. And a one-day conversion means there's no transition period and there's no grace period. There's no transition period on the front end. That means on Wednesday, September 30th, you have to use ICD-9 codes. You cannot convert to ICD-10 early. And then on Thursday, October 1st, you must use ICD-10 codes. Right? It's a one-day switch. Now you might say, how is that different from what other countries have done? A lot of countries have had a one-day conversion like that. And that's true. But what's different about the one-day transition here in the United States is this isn't our first conversion date. ICD-10 has been delayed 3 times already. Twice by CMS, twice by Medicare, and then most recently last spring by Congress. That uncertainty has actually been a disservice to a lot of practices. A lot of practices are further behind than where they should be at this point because of the uncertainty around that date. Many people, many organizations are hoping that it might get delayed again. And rather than taking the steps to be prepared, they're hoping that that date does not come to fruition. It's a lot like the story of the boy who cried wolf. Everybody probably remembers that story from your childhood. At the end of that story, the boy has lost his credibility. But when the wolf actually comes, who pays the price? It's not the boy who suffers, it's the sheep. It's the sheep owners. And it'll be just like that when ICD-10 arrives for practices who aren't prepared. Yes, the government has done us a disservice in this. Yes, they have lost their credibility in communicating this date. But for practices who are unprepared, it is not the government who will suffer. It's the practice. It's the doctors in that practice. It's the employees in that practice. Right? Ultimately, it may be the patients in that practice who end up paying that price. And that's very difficult. It's difficult for administrators. It's difficult for billing managers, for project managers to get everybody on board when there's not clarity on the date. Another thing that makes ICD-10 uniquely difficult here in the United States is that it's a big change for physicians. Now again, you might say, well, no, wait a minute. It was a big change for physicians in Canada and Australia and England and France and everywhere else that's already moved forward with ICD-10, and that's true. But what's unique about the United States is that our doctors cannot slow down. Our providers are not government employees. They're small business owners. And under our current fee-for-service model, they're paid for their time. They're paid for their productivity, for their volume. And if they have to slow down to deal with an unfunded mandate like ICD-10, that's money out of their pocket. They cannot slow down. Not to mention the fact that it's an area that they're not particularly interested in. Right? Most doctors did not go to medical school to be a coder. They don't want to spend a lot of time learning the new code set. They don't want to spend a lot of time in an ICD-10 training class. So as an administrator, how do you prepare them to be successful in ICD-10 when they don't want to spend any time up front learning about it? We're going to talk about some strategies to do that. But you have to appreciate that that is a very, very difficult position that you are in trying to lead that change in your practice. And the last point here, I think this is the most critical, is what's at stake. We've had a lot of change in healthcare in the last 6-7 years. Right? We have had the e-prescribing. We've had PQRI, PQRS, meaningful use stage 2, a lot of government programs. But this one is different. All of those prior government programs were optional. You could earn an incentive payment. Right? There was a possible threat of a 2% penalty down the road. They were gradual. They were phased in. ICD-10 is none of those. ICD-10 is a one-day change. ICD-10 is mandatory, not optional. ICD-10 is for all payers, not just your government payers. And ICD-10 has no incentive payment, all stick, no carrot. All HIPAA-covered entities are required to move to ICD-10. So that means it's not just Medicare and Medicaid, it's all of your commercial carriers as well. There's a lot at stake when we look at ICD-10. And it's not just about getting an ICD-10 code on the claim out the door. You've got to jump through the hoops and hurdles to get that claim paid correctly. And Medicare may want it one way, and Blue Cross Blue Shield may want it another way. They do that today in ICD-9. They will continue to do that in the future in ICD-10. That's what makes ICD-10 difficult. There's a lot at stake. There's a lot at stake. We've got to protect our doctors' time. And a lot of organizations have been waiting and hoping for additional delay from the government rather than taking the necessary steps to be prepared. And so I want to share with you, if you're trying to catch up, if you're still working on some of your plan, some of the mistakes we see other practices make when they're planning for ICD-10. The first mistake is to assume that ICD-10 is really just a coding project. Right? I've got my coders, I've got my billers, they're going to boot camps, they're getting certified, they're getting trained and ready to go on ICD-10, but it's not going to impact anybody else in the practice. Right? That's a half-truth. Yes, it's a big change for coders. It's a big change for billers. But it's not isolated to just them. A lot of other people make a similar mistake, looking at ICD-10 as really an IT upgrade. Right? You see a lot of checklists that say communicate with your vendors, make sure you're on the right versions. And again, those are all good recommendations. Those are all essential parts of any successful ICD-10 plan, but it's not a complete plan. Yes, check with your clearinghouse and check with your practice management vendor and check with your EHR vendor and make sure you're on the right versions of their software. But we have all learned it's not about just being on the right version of a piece of software. You need to dig deeper. You need to ask the next question. How is it going to work? Show me how it's going to work. How is it going to impact our workflow? Will my providers do that? Will my billing staff do that? How much training is that going to require? How much time is that going to take? You have to look at ICD-10 holistically. And by that, I mean ICD-10 has to be a strategic initiative. And again, we recommend focusing on the big two risks of ICD-10. The first one is your doctor's productivity. And the second one is your revenue cycle efficiency. And when I say revenue cycle efficiency, what I mean there is how many people, how many labor hours does it take to collect that cash flow and at what rate? Because if I have to add additional staff, or I'm collecting less cash flow, or it's taking me longer to do it, any of those three are bad outcomes for the practice. We have to protect against that. I'll share a study with you that might help put some numbers to this. This is a study that was done by the advisory board. They do some very, very good ICD-10 consulting work. They looked at Canada's transition to ICD-10 to understand what the impact was. What were some of the hidden costs, not leading up to the conversion date, but afterwards, the long-term costs. And look what they put front and center. They put physician productivity front and center, a 10 to 20% decrease in physician productivity as a result of ICD-10. And I would tell you that is unacceptable. You want to get underneath the numbers and understand what happened? There were coders, there were billers going back to the physician asking for more detailed information. They were trying to code from the note, and they needed more detail. Tell me more about the anatomical location. Be more specific about the type of disease, about the onset of the disease, about the etiology of the disease. I need to know more about this. And that back and forth process, answering those questions, was taking between 45 and 90 minutes per doctor per day. Even if you cut those numbers in half, that is unacceptable in a busy physician practice, in a fee-for-service world here in the United States. We cannot have that. Where are your doctors going to find 22 to 45 minutes per day to answer these types of coding questions? They can't spend less time with patients. And it's not fair to ask them to spend that time at the end of the day answering those types of coding questions instead of spending time with their families. We have to push back against that. We have to put the right types of processes in place to make sure that that doesn't happen. So we're going to spend a lot of time talking about that. Now, but let's look at the coder productivity and the rework productivity as well, because those are also important. The coder productivity, you can see on the far left that there's a significant decrease in the first 12 months. As these resources are getting up the learning curve, as they're getting more familiar with that, they will regain some of that productivity. But you can see the long-term expectation is that they will never get back to their current levels of productivity. Long-term permanent decline in productivity of 5 to 10%. And that's significant because we cannot hire additional staff if there are no additional dollars for ICD-10. How do we make those employees more productive? How do we give them the tools and resources that they need to be productive so that we can avoid those types of productivity declines? And then on the far right-hand side where you see the rework productivity, you see an increase in denials, inquiries, adjustments coming back from the payers. Now, there's always a question of what is that going to look like in the United States. The best place to look for that is the early end-to-end testing results that Medicare has already published. We are seeing denial rates are doubling and tripling as a result of ICD-10. So what that means is for practices, if you have a 2 to 3% denial rate today, that may go as high as 4 or 9% in ICD-10. Not a catastrophic increase, but a significant increase. You want to make sure that you're prepared to be on the low end of that spectrum rather than on the high end. And we're going to talk about some strategies of how you do that. But we have to understand and have a clear picture of what the problem is first. So ICD-10 will be difficult for physician practices, both for doctor productivity and for the revenue cycle. Now, I don't want to be all doom and gloom here. I want to dispel some of the myths that a lot of people have, misunderstandings of what ICD-10 is and how difficult it's going to be. The first one, you always hear people push back against this, is the number of new codes in ICD-10. Right? I'm sure everybody has heard that, has seen something like this in the past that says there are 16,000 codes in ICD-9 today. And we're going to see that increase up to 69,000 codes in ICD-10. And that's true. But what most people don't tell you is that you're never going to use all those codes. Think about what you do today. You don't use all 16,000 ICD-9 codes today. Most practices use less than 2% of the entire code set. So we recommend focusing on the codes that you do use. And don't pay attention, don't worry about all the codes that you won't be using in ICD-10. You know, a lot of people like to publish infographics and funny pictures talking about some of the new ridiculous codes in ICD-10. Right, I'm sure everybody's seen this. This is probably the most infamous ICD-10 code out there, V91.07XD, this flaming water skis encounter. Right, everybody likes to laugh about that, and, you know, and it is. There's some funny pictures that can always go along with that. But what most people don't tell you is, believe it or not, that's already a code today in ICD-9. Very, very similar, E837.4. And you never use it. I haven't run into a single practice who uses that code today in ICD-9, nor will you run into a single practice that uses it in ICD-10. This is a distraction for a lot of practices. A lot of people who are opposed to ICD-10 use this as a smokescreen It's a scare tactic. They try to make you believe that there are so many ridiculous codes in ICD-10 that you could never be successful. And again, that's not helpful. It distracts you from being prepared, and it distracts you away from some of the more dangerous codes, the silent killers. And I'm talking about unspecified codes. Unspecified codes exist in ICD-9, and they exist in ICD-10. Now, in ICD-9, most practices use these to save space on a super bill. They use it as a catch-all. They use it to make the template easier in their EHR for their providers. And there are really no negative consequences in ICD-9. They're payable diagnosis codes. The problem is there are two significant risks to using unspecified codes in ICD-10. There's a short-term risk and a long-term risk. Let me talk about those briefly. The short-term risk to using unspecified codes in ICD-10 is that the claim may not get paid. Think at a very high level, why have all the payers gotten on board with ICD-10? Why have they invested in their infrastructure to rewrite their adjudication process to handle ICD-10? Why do they lobby Congress to continue moving forward with ICD-10? It's because they want the more detailed diagnosis information. They want the more granular diagnosis codes on their insured patient population, because long-term they want to use that information to drive down reimbursement rates, or at least drive down total reimbursement, drive down the total cost of healthcare. Now, they may not all do this on day one, right? Different payers may handle this differently. Some may pay unspecified codes for 3 months or 6 months. CMS came out with some information beginning of July that said they're going to pay those unspecified codes for 12 months. So you might get a little bit of relief there only on your Medicare claims, not on your commercial claims. But the risk, short-term risk, is a cash flow risk that claims using unspecified codes in ICD-10 will not get paid. The long-term risk of using unspecified codes in ICD-10 is that we are eventually moving away from fee-for-service, moving towards a pay-for-performance, a pay-for-quality, a pay-for-outcomes-based model. And as we do that, you are going to have to use the more specific ICD-10 codes in order to maximize your reimbursement. As we move towards that model, it's all about the expected outcome versus the actual outcome, the severity of your patient's condition. And you need the more specific ICD-10 codes to accurately reflect that, to maintain and then possibly maximize your reimbursement. You will need those more specific ICD-10 codes. All right? So when you look at this, when you look at these crazy codes, focus on the codes that you use today. If you're not using these E-codes, these external cause codes today, you don't have to use them in ICD-10. CMS has already come out and said there's no new national mandate required for practices to use the external cause codes if you're not using them today. Don't focus on the codes that you aren't using. Focus on the codes that you are using. And pay special attention to those unspecified codes because of the additional risk that they carry as we transition to ICD-10. All right, so how do you do that? How do you start? What we recommend doing, and we've done this for all of our clients, is look at the codes that they use today and do what we call ICD-10 conversion analysis. You look at this across specialties, and what you see are most practices use somewhere between 200 and 300 ICD-9 codes today. And that covers 95+% of their patient encounters for the year. You can get these codes off of a frequency report in your practice management system, off of a paper charge ticket or super bill if you're using one of those, but most people fit in that range. When we take those and we convert them into ICD-10, what you'll see are two things. Number one, a significant increase across all specialties, right? And number two, orthopedics is the outlier. So if you're an orthopedic practice, or if you are a primary care office that sees some patients for musculoskeletal type issues, sprains, strains, fractures, those sorts of things, those are going to be the most difficult areas to convert to ICD-10. Now, we do want to go a step further because not all codes can be converted equally. We categorize those into three different risk categories: low risk, moderate risk, and high risk. The low risk are ICD-9 codes that have one corresponding ICD-10 code. For most practices, this is somewhere between 15 and 40% of the codes that you use most frequently fit into this risk category. And the bad news is it's not 100%. The moderate risk codes are those that have between 2 and 10 choices in ICD-10 for each ICD-9 code, and the high risk are those that have 11 or more ICD-10 choices. Every practice is going to have codes that fit into each of these categories. I'll show you some examples of each. Right? And when we do this ICD-10 conversion analysis, what we're trying to do is taking the codes that you use most frequently, providing that summary data up at the top. That's what you saw on the previous slide, 234 codes in ICD-9, 1,147 in ICD-10, but also give you the line-by-line detailed information. Because you'll see, like look at this first example for cough, 786.2, that's the ICD-9 code, but you can see there's only one ICD-10 code. The new code is R05, and it's still a cough. That's an example of one of those low-risk codes. Unfortunately, everything doesn't fit into that category, so let's look at the next one, 354.0, carpal tunnel. 3 codes in ICD-10, and when you look at the descriptions, look at this. This is what I think is really interesting. Carpal tunnel, unspecified arm, left arm, right arm. Right? Who's ever heard of an unspecified arm? Every patient has 2 arms. Well, some have 1, but I've never seen anybody with a 3rd arm. But that's a valid ICD-10 code. It's in the code book if you go look it up. But this is where you have to think about some of those unspecified codes. What's the negative unintended consequence of using a code like G56.00? Is Blue Cross going to pay that claim for a face-to-face encounter when we didn't know which arm the patient was complaining about? You've got to be careful about that. And then look at the next choice where you've got 428.0, congestive heart failure. Again, you've got new detail in ICD-10 as far as, is it systolic, is it diastolic, is it combined? What about the onset? Is it acute? Is it chronic? Is it acute on chronic? That's where you have to be more specific. That's one of the things that I really like about this ICD-10 conversion analysis is it shows you 2 things. Number one, it shows you here's where the increase is. Here are the parts that are going to be easy. Here are the parts that are going to be hard. Right? It shows you the status quo won't work. I can't have the same process if there are 230 codes that I need than if there are 1,100 codes that I need. But it relieves some of the anxiety. It's not 69,000 codes for your practice. And when you look at the descriptions, you'll see the new concepts are not foreign. They're familiar. There's nothing on here about walking into a lamppost or being struck by a turtle, right? Or a flaming water skis encounter. They're all familiar concepts to you and your providers. So I think that helps relieve some of the anxiety. I certainly recommend doing an ICD-10 conversion analysis as a next step if you haven't already. We offer this as a free service for people who attend one of these webinars. So if you'd like to do this ICD-10 conversion analysis, you can let me know in the questions panel, or you can email us your most commonly used codes in an Excel spreadsheet, and we'll send you back the results that we were just looking at for your practice. I think that's helpful to share with your providers. I think it's helpful to share with your staff. It's a good starting point to identify which areas are going to be difficult and which ones are going to be easy. If you're a numbers person, if you're a data person, it's a great way to look at it. Now, if you're more of a visual learner, let me show it to you this way, and I'm going to pick on the American Academy of Family Practice for a second, because they put this on their website. It's a super bill, it's a charge ticket, it's one other way to look at this, that they recommend their members use. Now, it looks like every super bill that I've ever seen. It has the CPT codes on the front, it has the diagnosis codes on the back, works very, very well on ICD-9. In fact, we did a national survey last year and found 54% of practices are still using a paper charge ticket, fee slip, encounter form, super bill, whatever you want to call it. Now, here's what caught my eye. The American Academy of Family Practice also had on their website an ICD-10 version. And it looked like this. The front side stayed the same. No changes there. But the back side looked like this. It was 8 pages long. And I think while this may be a, quote, ICD-10 compliant solution, it has ICD-10 codes on there instead of ICD-9. It does nothing from a productivity perspective. Can you imagine trying to put an 8-page super bill in your doctor's hands? I don't think that would work very well. So that's the problem. That's why the status quo won't work. You can't do an 8-page super bill, and you can't do a jumbo super bill either, right? That says we'll just make the piece of paper bigger and make it 4 feet tall by 3 feet wide. It's a real estate problem. I'll use this as an example to talk about some of the things that you need to be thinking about, and thinking about from a productivity standpoint, not just a compliance standpoint. Let's look at this charge capture process. And some people would say, well, we don't use that. We have doctors that write in a description and somebody looks it up downstream, or we code from our doctor's note on every single visit. But I want you to remember, it's not just the codes that are changing, it's the description, it's the detail, it's the concepts that are changing as well. You've got to be more specific. And if you've got doctors writing in a description or dictating a note that somebody's going to go read, or using the EHR template, you've got to make sure you're getting the level of detail required so that you don't have that back and forth problem between the coder and the provider, between the biller and the provider, that caused that 10 to 20% decline in physician productivity in Canada. And we're going to look at 3 different ways that we've seen practices address this. But when you think about trying to solve a problem like this, what you have to understand is, why does it work so well today? And it's really the doctor's muscle memory that protects their time, that protects their productivity. They can fill this out with their eyes closed because they know where the codes are on the page. So what do we see practices doing? I'll highlight 3 options. I'll move through them quickly. The first is to hire certified coders. Now, I see this more in the hospital setting than I do in the ambulatory setting, because they have more money. But for a practice, the challenge is that coders are expensive and that they're getting more expensive. If you're going to go down this route, make sure that you get coders who have been certified, who've been trained, and have had some experience with ICD-10. But you do need to be prepared that they are going to be less productive in ICD-10 than they are in ICD-9. That's not their fault. ICD-10 is just more complicated. So we need to make sure that you're prepared for that. That's why practices struggle with this. If the economics don't make sense in ICD-9, they get worse in ICD-10, not better. So I see more practices do option 2 or option 3. but I wanted to make sure at least brought that up. So option 2, and this is easier for me to say on a webinar than it may be for you to actually do, but is just get all your doctors to do it correctly in their EHR. We see a lot of groups that struggle with this, and when they struggle with it, you ask them why. It's not because the doctors are non-compliant or because they're technology averse. It's because they're worried about their productivity. We've probably all sat in meetings where doctors are counting clicks, and that's an important thing. They are paid based on their time. They're paid based on their productivity. It's not enough just to be on a certified EHR, right? You have to make sure that it works for the doctor's workflow. And the challenge is, if doctors struggle with that in ICD-9, if your doctors struggle with that in ICD-9, for most practices, it's going to get worse in ICD-10, not better. That's why you have to go further than just making sure you're on the right version. If you're going to go down this route, make sure you ask your EHR vendor, show me how it works. Show me what it's going to look like. How long is it going to take my providers? How many clicks is it going to take? Are they going to get to a specified ICD-10 code? Or are they going to be using some of those risky, unspecified codes? Because the way that most EHR vendors have handled this is through a code search process. And that doesn't sound problematic until you start to get underneath it. Most people think of search like Google, right? We use those words interchangeably now. Google has trained us in that way. You start to type a description of what you're looking for, you see the search results, and on Google, 99% of the time, the answer that you're looking for is at the top of the list, right? That's why everybody spends dollars trying to get the #1 search results in Google. That's the problem of code search. It doesn't work that way. If you search for diabetes and you get 50 search results, you have to read through all of those choices to choose the one that's most accurate. Or maybe your vendor took a drill down approach, which asks the provider a series of questions and ultimately gets to the right code. You've got to make sure that you look at that and how that's going to work. Will your doctors do that? And if they don't, or if they pick the first one on the list, is it going to be an unspecified code? Because oftentimes it is. If you sort in code order, if that's how the search results are displayed, the unspecified codes are at the top of the list. So think deeper, think further through your workflow when you're trying to protect your doctor's time in ICD-10. Now, the third option, I'm certainly biased, is you can use an electronic superbill, call it Capture. That is designed in such a way to look like the paper superbill. That shortens the training time for the provider, protects their muscle memory. They know where the codes are on the screen, just like they know where the codes are on the page. But it also makes sure that the revenue cycle team gets the right data that they need the very first time, right? So that they're not having to go back to the doctor and have the back and forth conversation that's disruptive for the revenue cycle process and for the physician. All right, so let me take a second again. Sometimes a picture is worth 1,000 words. I'll show you what this looks like. And I'm going to do 2 encounters, and I'll do them side by side. This is Capture, an electronic superbill. We custom designed each one to look like the paper superbill does today. I'm going to do 1 encounter in ICD-9, and then we'll turn around and do that exact same encounter in ICD-10. So if I've got a level 3 office visit, maybe we also did a metabolic panel. I flip over to the back side, I've got my diagnosis codes, right? And what I'm going to do is I'm going to click on cough, and then carpal tunnel, and then CHF. Those same 3 codes we looked at before, pretty fast and easy for me in ICD-9. Instead of circle, 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 I went click, 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 right? Okay, everybody really understands that. Let's look at the exact same encounter, this time in ICD-10. You know, I want you to think with me, if you will. I'm one of your providers. I haven't come to any of your ICD-10 training classes. I'm going to show up on Thursday morning, October the 1st, and try to do an encounter in ICD-10. See if I can figure it out as I go. I've got my level 3 office visit, my metabolic panel. Nothing has changed. Exact same thing, no change to CPT codes. But what about the back side? Is it 8 pages long? No. This is the magic of what you can do with an electronic superbill. It looks exactly the same as it did the day before. So far, so good. When I click on cost, watch this. This is the first time you'll notice a change. It highlighted that in green instead of in yellow. It's just a visual cue to the user to let them know something has changed. It's an ICD-10 code. It's one of those low-risk versions that it changed automatically for me. I wish everything were that simple. Let's move on to a more difficult example like carpal tunnel syndrome. When I click on this, what you'll see is it gives me a pop-up with my choices. It can't select that for me automatically. Now you'll notice it's organized those so I don't have to read the description 3 times. I can see that it's left arm, right arm, or that third choice of unspecified arm. Now, coding is part art and part science. There are places where reasonable people will disagree, but most of our clients are choosing to not show their doctor the choice for unspecified arm. If it's a code that you don't want to use, if it carries the short-term risk of a claim not getting paid, the long-term risk of declining reimbursement in an outcomes-based reimbursement model, let's start out the right way. Don't show them those choices. So if it's in the right arm, they've got one extra click, it closes the pop-up window, it puts in the new ICD-10 code and description, and I'm done. Okay, well, let's look at a more complex example like congestive heart failure that has multiple choices, 15 different options here. And you'll see we've organized this into 2 dimensions for you so that you can see the new documentation requirement, the new coding concepts, where you have the type of heart failure across that horizontal axis. Is it systolic? Is it diastolic? Is it combined? And you have the onset on the vertical axis. Is it acute? Is it chronic? Is it acute on chronic? So I don't have to read through all the choices. It's organized in a way that's intuitive and lets me select the right code for chronic systolic congestive heart failure in one click. It puts in the new code and description. I'm done. I'm done. It doesn't require a lot of training, but gets my billing team the right data that they need. You know, one last thing, if I go to this summary tab here, it lists out, again, you can see the ICD-9 descriptions on the left, the ICD-10 descriptions on the right for your providers who might still dictate or document manually. This serves as a helpful reminder for them. A lot of doctors like to use the paper superbill to dictate from as a reminder at the end of the day. They can do the same thing in the electronic world. Some of them even have staff that print it out for them, but it reminds them of where they need to be more specific. Instead of just saying CHF, they remember to say chronic systolic CHF, so that I've done my documentation training as I go rather than expecting them to spend a lot of time over the summer learning. It also reinforces that over the first few weeks as they're learning ICD-10. It helps them remember where they need to be more specific, because what we're trying to do is protect their time and protect the revenue cycle. Now, I know I've spent a lot of time talking about the physician because, again, if you don't do that, if you don't get that done correctly, the rest of it doesn't matter. But let's talk about the revenue cycle for a few minutes, and then I'll try to answer as many of your questions as I can, because it is a big impact for the billing team. It's not just a one-day change for them. They're going to be dealing with ICD-10 for months and possibly years into the future. And let's zoom out. Let's think about this from a big picture perspective. We get paid for CPT codes today. We get paid for CPT codes today in our fee-for-service world. And that's true in ICD-9 and in ICD-10, that you have to have a diagnosis that supports it. Right? Now, if only it were that simple. It's not about just getting codes out the door on a claim. You've got to jump through the hoops and hurdles from the insurance carriers to make sure that those get paid correctly. And not all carriers do that the same way. Medicare may want it some way, and Blue Cross may want it another way. You've got to make sure that you do that correctly. Now, you deal with that today in ICD-9, right? We've been using ICD-9 for the past 30 years. And yes, the rules to the cat and mouse game change from time to time, but the volume of change is relatively stable. And you probably have people in your office who know a lot of these rules in their head. The problem is that the rules of the game and all of that head knowledge that your people have go out the door overnight. We're still going to play the cat and mouse game, but the rules of the game will change. And again, each payer is going to probably handle that a little bit differently. Because remember, the payers have never done ICD-10 before either. They're going to be learning as they go, and they're going to be making adjustments as they go. So it's not just a one-day change for your billing team, whether they're external or internal to your organization. They're going to have to be making adjustments in the months following ICD-10. As the payers change their adjudication algorithms. And they do that at different rates and in different detail. You're going to have to be able to respond to that change, and that change is going to be at a faster rate than anything we've ever seen in our careers. It's going to be a very high change environment. And so what we have to ask ourselves is, how are you going to manage that change? What's your process going to look like? What types of resources do you need? Who on your team is going to be responsible for that? And maybe the scarier question is, what happens if you don't do a good job of that? Right? So it's not just a one-day change for our billing teams. It's a marathon, not a sprint. And if you're going to run a marathon in October, the best thing that you can do is to start getting in shape today. Get your denial rate in as best shape as possible. Make sure you have a process to respond to the changes that are coming from the payers. And what we recommend for our clients is what we call a closed-loop denial prevention process. Anybody can do this. We obviously have some tools that help make this easy, but here's what we walk through with our clients. We say, look, you're never going to rid the world of denied claims. There are always going to be new denials. There are always going to be new policies. But here's what you can do. When you see a new denial, go back to the beginning. Figure out what went wrong and what you can do to prevent it from happening again. Build in a new rule that's built into a software application, not into individuals' heads, not on a sticky note, not in a binder. Put it in an application that can remember every single time. That way, the next time the exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the same way for every single employee every single time. Whether it's my most senior certified coder or my newest billing clerk, they both have the same actionable information about what's wrong and what to do to correct it. That's closed-loop denial prevention. If I can do that today in ICD-9 and get my denial rate as low as possible, right, that says I'm in as best shape possible to run a marathon beginning on October 1st. And if you've exercised this process, you're able to respond quickly when the adversity comes. Because it will. Think about what we're doing with ICD-10. None of us have done this before. It's a bit like being a pioneer. There will be changes. You will have to be able to respond quickly. And you want to be well positioned in order to do that. That's part of what will make the difference between ICD-10 compliance and ICD-10 productivity. This is the last slide, and then I'll try to answer your questions. But what I want you to think about is think about your practice. What do you want your practice to look like in October? What do you want your practice to look like in November? Think about your providers. Think about your billing team. What do you want that to look like in October? Is the goal simply to be able to submit claims that have ICD-10 codes on them? Or is the goal to have looked at the workflow and make sure that you've made the necessary changes to optimize that in an ICD-10 world? Are my doctors going to be staying late to answer those follow-up coding questions? Or are we able to protect their time so that they can remain focused on taking care of patients? Because that's what our patients are going to expect. They're not thinking about ICD-10. They're expecting the same high-quality level of service that they get today. And that's why your doctors got into medicine. What about the billing team? Are they going to be working nights and weekends trying to get claims out the door? Or are we going to make sure that they get the data that they need the first time? Are they going to have the tools that they need to respond to changes that come from the payers? Right? Or am I going to have to outsource part of that work or hire additional employees to keep my cash flow coming in? And that's the challenge. I can't hire additional staff if there's no additional revenue. Any additional costs that I have are going to make me less profitable than I am today. That's the difficulty. And a lot of practices won't see that in advance. They'll look up at the end of the year and may not be paying out their quarterly bonuses to their providers because they were less profitable in the fourth quarter than they were in the third quarter. They're less profitable in 2016 than they were in 2015 because they didn't plan ahead. And it doesn't have to be that way. You can get out ahead of this. You can be successful in your transition to ICD-10. And some practices will find processes that they can automate, that they can make better. Not because of ICD-10, but just because of the timing. So think about what you want your practice to look like. So I hope that that will be helpful for you. I hope that this has spurred some thought for you. If there's anything that we can do to help you, or any questions that you have, if you'd like a copy of the slides or a link to the recorded version, please let us know. You can use the questions panel for that. But with that being said, let me turn it over, and I'll try to answer as many questions as I can before we reach back to the